Let us right away start with the subject. The subject is very wide. Okay, before I forget, thank you very much, Jyoti, and thank you very much for the entire team. Thank you very much to the entire team for inviting me here. So ultrasound and infertility is a very, very wide subject, but let us just take an overview of what we can do with ultrasound for an infertile female. So we can diagnose uterine pathologists, ovarian pathologists, tubal pathologists, endometriosis, assess the tubal patency, calculate the stimulation doses, so the ovulation induction doses, to decide the time of trigger, to decide the type of trigger that we want to give for the ovum pickup, for the embryo transfer, it's a guide, and of course for the luteal phase assessment, and moreover even to evaluate and diagnose the complications of infertility. I don't know how much I can cover. The moment my time is over, I'm going to stop, but let me see how much I can cover with this. Ultrasound, especially when you are talking about the uterine abnormalities, remember for the Mullerian abnormalities, 3D is now considered a gold standard because we can see the coronal plane, we can see the outer contour, and we can also see the endometrial contour. So that is why whatever classification you are going to use, it is 3D ultrasound which is now considered a gold standard for differential diagnosis for all duplication abnormalities. Yes, I do agree that whenever you have a coordinate uterus and you are suspecting a rudimentary horn and you don't get it, or you cannot see it on ultrasound, or when you are suspecting agenesis of the uterus, these are the two conditions where MRI is required. So that is about the Mullerian abnormalities. Coming to the uterine pathologies, which may be myometrial, which may be endometrial, and starting from the endometrial pathologies very quickly, and only the salient and the diagnostic points. We all know polyp is a solid projection inside the endometrial cavity. You are going to always see it as an ecogenic structure. I would say mildly more ecogenic than the myometrium. If they are very small, they may be missed because they have a very subtle ecogenicity. In that case, you have to follow the central line. If it shows an abnormal curvature, it may indicate a polyp underneath. Whenever you suspect the polyp, always use a Doppler. Whether it is a single polyp or there are multiple polyps, you are going to see the feeder vessels. A single feeder vessel is what tells you, yes, it is a polyp and nothing else. The closest, yes, of course, you can, because it's an endometrial lesion, you can also put some saline into the endometrial cavity. Sono saline infusion, sonohystero, and that can show you the endometrial lesions beautifully, of course, on 2D as well as on the 3D. Even 3D alone may be a good guide to tell you whether that it is a polyp. The closest simile would be if the polyp is large and it's filling up the entire endometrial cavity, would be endometrial hyperplasias. Endometrial hyperplasias, rather than being completely hyperechoic or ecogenic and homogeneous, they usually show tiny anechoic areas, and if you see that the anechoic areas are very tiny and they are there but not variable in size and not multiple, then it is more likely to be a stromal predominance in the hypertrophy. Whereas if you are seeing multiple anechoic areas variable in size filling up almost the entire endometrial cavity, it is more likely to be glandular predominance. In both these conditions, the vascularity is not very abundant, but it is symmetrically distributed, it's regularly distributed, and the endomyo junction is always intact. Instead, yes, if you think that a thickened endometrium and thinking about the malignancies usually will, if it is confined to the endometrium, may not show disturbance in the endomyo junction. If it is widespread, yes, the endomyo junction will be affected, but if you put on a Doppler, the vascularity is heterogeneously distributed, unlike the regularly distributed vascularity which you see in the hyperplasia. So, and of course, it would be a very low resistance flow. If at all, again, if you are seeing this picture and suspecting vesicular mole, of course, you have beta HCG to compare with, and moreover, of course, as I told you, in the hyperplasia, the vascularity is less. In the moles, the vascularity is very abundant. Next, endometrial pathology, endometrial synecdoche, persistently thin endometrium in proliferative as well as in the secretory phase, sometimes may show calcification. If there is a calcification, you will see a posterior shadowing. If it is a thin endometrium, you are seeing hyperechoic flex but no posterior shadowing. This is not a calcification. This is usually either fibrotic strands of chronic endometritis, or it is collapsed myometrial cysts of adenomyosis. If at all you are having a persistently thin endometrium, it is always best to put some fluid inside. If the synecdoche are not very strong and tight, then you can see some fluid percolating into, or I would say going into the endometrial cavity, and you can see beautifully the synecdoche there. Even on your 2D, your diagnosis will be confirmed. Sometimes when the synecdoche are very thick and tight, that's when they'll hardly allow any fluid into the endometrial cavity. Remember, a very important sign is that whenever you are seeing a very thin endometrium persistently and you are seeing tiny loculi of fluids inside, this confirms your diagnosis of synecdoche even without putting any fluid inside. Synecdoche we know are very common, or the thin endometrium is very common with chronic endometritis. When we are talking of chronic endometritis, persistently thin endometrium, irregular endomyojunction and scanty vascularity inside the subendometrium and in the endometrium. But tuberculosis is the major concern to many of the people. Apart from this, you may see tiny polyps, so micropolyposis. You will see hyperechoic spots in endometrium, in the junctional zone, in the myometrium sometimes. In the mid-proliferative phase, you will have fluid in the endometrial cavity with hyperechoic central wall or the inner wall of the endometrium and no vascularity in the subendometrium. Narrow cavity, we all know, is often seen with any chronic endometritis, and it's also seen with tuberculosis and along with the scarring. A very important sign that you may see with tuberculosis, most consistent, I would not say it is a specific sign, but most consistently is vertical orientation of the interstitial part of the tube. Instead of the normal direction of the interstitium, which is like that, one of the interstitial parts of the tube may stand up, and that may tell you, yes, it is tuberculosis. Apart from this, you will also see myometrial cysts with hyperechoic margins, very similar to what you would see with adenomyosis. But adenomyosis, when you see the myometrial cysts, will show you peripheral vascularity. Myometrial cysts of adenomyosis will show you peripheral vascularity, but myometrial cysts of tuberculosis will not show you any peripheral vascularity. And this is a very important sign because in both adenomyosis as well as in the tuberculosis, you will have irregular junctional zone. You will have a thin endometrium in adenomyosis also if it is a wide severe adenomyosis. And you have myometrial cysts. It's the vascularity which will differentiate between the two. If we are talking of adenomyosis, apart from the myometrial cysts that you have, we all know we may also have hyperechoic dots and lines. The junctional zone may be irregular, may be obliterated, or may be interrupted because of hyperechoic strands or anechoic areas in the junctional zone. You also will see abnormal curvature of the endometrium beyond the fundus. So beyond the mid half of the body, the fundal endometrium shows a reverse curvature, which is called a question mark sign, which may be because of asymmetrical involvement of the uterus in adenomyosis or maybe because of adhesions. If you put on a Doppler, not all adenomyosis are hypervascular. Remember, there are some adenomyosis which are hypervascular, some which are hypovascular. The ones which are hypovascular will respond to the medical line of treatment. The hypovascular ones will not respond to the medical line of treatment. Whether hypo or hypervascular, the vessels that you see in the adenomyosis, they will have larger diameter than the normal spiral vessels, and instead of being arranged parallel to each other and perpendicular to the endometrium, they are chaotically arranged, and they disregard the margins of the lesion, run through and through, and that these are the signs of adenomyosis. Fibroids, we all know, it is a well-defined oval, round, lobulated lesion. Maybe if it is degenerated, may show heterogeneous echogenicity. Peripheral vascularity is which is diagnostic even if it is degenerated and will show internal vascularity. The peripheral vascularity is still there, and the vessels that you see inside the degenerated fibroid will be limited by the peripheral vascularity. They will always respect that peripheral vessel, will never go beyond that, and that tells you yes, it is a fibroid and it's not an adenomyoma. As we all know, fibroids may undergo n number of types of degenerations, all lead to heterogeneity, which may be cystic, which may be calcification, which may be just hyperechogenicity because of myxoid, or may be truly heterogeneous hyper and hyper in the rate degeneration. Fibroid location is very important, which can again be confirmed especially in relation to the endometrium when it is type 0, 1, 2, 3, and in these cases it is 3D ultrasound, which is going to be very, very helpful to you. So that is about the major lesions that you come across. Of course, there is enhanced bilateral vascularity, RPOsis, which are all fully, always ultrasound is the modality of choice for the diagnosis. Then coming to the next cell lesions, I'm just talking about the lesions that we very commonly come across and we get confused about. And one is when you are finding a lesion which is in the adnexa, which is completely anechoic, no septa, no internal echogenicities, and then you first have to decide whether it is intra-ovarian or extra-ovarian lesion. Remember, whatever the morphology of the lesion, if you are seeing the lesion and you are seeing the ovary and you push the probe in and out, or your probe is in and you press with the other hand on the abdomen, bellot the abdomen, and you can either separate the two as you are seeing there, or you can slide the two over each other. This tells you it is extra-ovarian. If you cannot do that and you are seeing a ream of ovarian tissue, or you are seeing a beak of ovarian tissue, this tells you it is an intra-ovarian lesion. If both these signs are absent, then it is extra-ovarian and adherent to the ovary. So that tells you surely what is the organ of origin. Now coming to the different types of lesion that we very common come across, and we started with an anechoic lesion, and if that is the lesion which we are seeing and it is intra-ovarian, the only possibility is I would not say only, but the most common possibilities are follicular cyst, and it may be a simple cyst. Remember, any follicle that is larger than 25 millimeters, only then will you call it a follicular cyst. Anything smaller than that at any stage of menstrual cycle is not a follicular cyst, and functional cyst is a very, very loose term. It just tells you a cyst that is arising out of an abnormal function. Please don't use it. You will confuse yourself, you will confuse other people also. So whenever you see it in the follicular phase, you put on a Doppler, and you'll see a beautiful ring of color. Why beautiful ring of color? Because a follicle, even when, as soon as the follicle gets dominance, it starts pulling blood vessels towards itself. So if it is an active follicle of that cycle, it's going to show you a nice ring of color, at least covering half of the follicle, 1/3 to half of the follicle. But if you are seeing only scanty vascularity and the lesion is more than 25 millimeters, that's when you may say it is a follicular cyst. If there is no vascularity at all, that means it is either a residual follicle of the previous cycle or it is a simple cyst. Whenever you are seeing such a lesion, there is no risk of malignancy, and therefore always do a follow-up for this lesion after 2 to 3 weeks. Follicle is going to rupture, follicular cyst is going to start regressing, simple cyst is going to remain as it is, and the residual active follicle is going to regress. If instead you are seeing a cystic lesion with multiple and internal echogenicities, which may be hemorrhagic, and if they are hemorrhagic, it is going to be a hemorrhagic cyst or a corpus luteum. When I say corpus luteum, I mean that there is an active flow surrounding. When I say corpus luteum, it is still producing some amount of progesterone, and whatever, of course, if you see this lesion for the first time in the secretory phase, you always suspect a corpus luteum. First put on a Doppler, excellent flow, low resistance flow, tells you yes, it is a corpus luteum and it is nothing else. But if the flow is scanty, it may be inadequacy of the corpus luteum, which is the first possibility. If you are seeing this lesion for the first time in the proliferative phase, then of course we don't usually suspect an active corpus luteum. If you put on a Doppler and no flow at all, it is a hemorrhagic cyst. Hemorrhagic cyst is the term only to be used for a corpus luteum which has stopped functioning but has not resolved anatomically. So it is a functionally non-active, it's hormonally non-active, therefore it shows no flow at all. But if you see such a lesion in the early proliferative phase, you put on a Doppler and you are seeing flow. If it is a nice flow, just like you are seeing in the corpus luteum, then it is a residual active corpus luteum of the previous cycle. Whereas if it is showing a scanty or a high resistance flow, it is a regressing corpus luteum. A regressing corpus luteum doesn't come in the way of stimulation. If it is a residual active corpus luteum and it persists till day 5 of the cycle, then these are the cases where you might have to omit the cycle. Day 2, n number of times you will see this, but whenever you see this, confirm it with the endometrial status. If you are seeing on day 2 a corpus luteum which has flows and you are worried about this corpus luteum affecting the follicle or the endometrium, see the endometrium. Is the endometrium thick? Is that thick endometrium showing flow also? Because even blood will show a thick hyperechoic endometrium. So if it is thick, hyperechoic and is showing flow, yes, you agree that that progesterone is acting on the endometrium, and these are the cases where I will have to re-evaluate this patient. Instead, if you are seeing low level echogenicities only inside the follicle, inside the cystic lesion, and you are seeing hyperechoic walls and you are seeing scanty flow, this is an LUF. LUF shows hyperechoic walls, low level echogenicities, no hemorrhagic echogenicities as a rule, because it is an unruptured follicle, it cannot be any hemorrhage inside. All these lesions are physiological lesions and they are bound to start regressing within 2 to 3 weeks and completely regress in 4 to 6 weeks. If they do not, then they definitely require a further investigation. Apart from this, the common pathologies that we come across, the ground glass echogenicity, everybody knows, but remember, not all endometriomas will show just a ground glass echogenicity. Many a times you will also see a fluid level like that. Sometimes you will also see some fibrin strands and hemorrhagic echogenicities, because it is ultimately blood or blood products. What is then diagnostic of endometrioma? One, you are seeing hyperechoic flecks in the walls. Those flecks in the hyperechoic walls or flecks on the fibrin strands is what tells you are seeing this flecks. That is what tells you it is an endometrioma. This is because of hemosiderin or cholesterol. Or if you rotate the probe, you will see a fluid level. A fluid level is what we call it. You are seeing a high echogenic fluid here and anechoic or a low echogenic fluid here. And this is because of the blood products and the solid blood products in the debris or the whole blood posteriorly, which is showing hyperechogenicity, and the serum anteriorly. At times you may also see tiny particles falling inside. So it looks like because of the gravity, there are tiny particles which are trying to settle down. This is called an acoustic streaming sign. This is also typical of endometriomas. Of course, it may be also seen in any cystic lesion which contains thick fluid. But if I say endometrioma, 1, hyperechoic flecks, 2, pain on probe pressure and possibly adhesions. Pain on probe pressure is something which confirms, yes, it is endometrioma and it is no other lesion containing blood. So that is about endometrioma. Then we may also come across very often with dermoids. Dermoids we all know is a 2D diagnosis, but dermoids also may show a typical fluid level, again very similar to this but opposite. In dermoid, the echogenic fluid is seen anteriorly. Why I am saying anteriorly is because this is a longitudinal scan, and in longitudinal scan this is anterior, this is posterior, this is caudal, and that is cephalic. So you are seeing echogenic fluid anteriorly, which is the sebaceous material, and posteriorly you are seeing the fluid. You may see hair balls, you may see hyperechoic dots and lines, you may see hyperechoic tooth-like projections with posterior shadowing. You may have hyperechoic blades with posterior shadowing, hyperechoic balls with posterior shadowing. Something very typical is tip of the iceberg sign, where you are seeing a snowball like structure where you cannot identify the posterior margins, which appears very similar to the bowel gas, but it is not bowel gas because you can actually see the beak of the ovarian tissue there. Because you are seeing beak of the ovarian tissue, it is intra-ovarian. You are seeing the ovarian tissue all around. So it is intra-ovarian, and this is typical of a dermoid. So a snowball where you cannot identify the posterior margins. Never painful, never vascular. Now coming to the ovulation disorders, which may be like poor reserve ovary or PCO patients. Now if at all, yes, we all know multiple follicles more than 20, size more than 10 cc, but we don't find these findings are not consistent. They are not seen in every patient. There are n number of papers which have come over the time. You cannot have a same cutoff for all age groups. There are n number of papers which have come. You cannot have the same cutoffs for all ethnicities. What is consistent then? The consistent thing is the stromal abundance. And this is what is you can see on your 2D scans as hyperechogenicity of the stroma 1. It at times you may also be, I mean, if at all you want to, you can measure the ovarian stromal volume. The ovarian stromal volume may be measured by 3D ultrasound, but if you are not going to do a 3D ultrasound, you can also measure the ovarian area on the strict longitudinal axis of the ovary, and you can deduct the follicular areas from the ovarian area, and you can measure the stromal area. And there are very good cutoffs, 5.5 centimeters square for the ovarian area and 4.46 centimeters square for the stromal area, which tells you yes, there is a stromal abundance. Even you can take a ratio of the stromal area to the ovarian area, and if you take a cutoff of 0.32 to 0.34, if the cutoff is beyond that, that means yes, it is a stromal abundance. And these are some very good papers and very good literature evidences which tell us that there is a stromal abundance. I'm not going to discuss more about this. Yes, there are n number of papers which have now agreed upon stromal abundance. Even the ESHRE 2018 amendment, it mentions stromal abundance is one of the major important features. Unfortunately, we are still looking for a more reliable way to calculate the stromal abundance, and therefore it is yet not considered as into the guidelines, but yes, it is definitely an important sign. Not only that, it is this stromal abundance which also correlates with the insulin levels. So if you want to decide this patient is going to, this patient may have insulin resistance or not, of course, blood test is the guideline, but you should also check the stromal abundance, and that will guide you whether a particular patient may be helped with ovarian drilling or not. Ovarian drilling is not to be done for all, as we all know. Not only that, you would also check the vascularity in the ovarian, in the PCO ovaries. It is very interesting to know that all the PCO ovaries, majority of them will have high vascularity. It is this reason that they hyperstimulate, but we also have resistant patients, because when we are talking of PCO, we have 4 different phenotypes, and there is a group which has high LH and there is a group which has high androgen. So the group which has high LH will show high vascularity, because it is LH which is responsible for new vessel formation, new angiogenesis, and it is also responsible for low resistance flow. That means if I am seeing a PCO patient, if I have a stromal abundance, if I put a Doppler and I see a lot of vascularity in the stroma, this means this patient has a high LH. So it also leads you to endocrinological, it guides you towards the endocrinological diagnosis also, and therefore may also help you better manage the patient and monitor. Coming to the poor reserve, we all know it is an ultrasound. Ultrasound can diagnose, of course, your AMH is there, but ovarian volume and the antral follicle count, we all know, is equally reliable parameter to assess ovarian reserve. Coming to tubal pathologies and the hydrosalpinx, for that matter, I'll just tell you one sentence, and that is any extra ovarian cystic lesion that changes its shape, I don't even say tubular or sausage shape, that changes its shape on rotation of the probe, unless proved otherwise, think of a hydrosalpinx, and this is something very important. So of course, you will see that as you see a cystic lesion, you rotate your probe, you sometimes may just have a beak-like extension, sometimes you may have a clear longish shape with incomplete septa. If it is an acute inflammation and hydrosalpinx, you will always see thick mucosal folds as seen here in the long section, and the same on the transverse section, which gives you a cogwheel appearance. Whereas if it is a hydrosalpinx, because of the chronic inflammation, you will have lesser dilatation of the tubes, hyperechoic walls, and adhesions are likely. Coming to the tubal patency testing, we all know saline infusion has been used by a lot of us. Of course, though HSG was there, now, at least we don't do HSGs anymore, but you can beautifully see here. Let me just start from the beginning. As you inject saline, You are seeing uterus and the ovary in the same section on the transverse section. You inject saline with either a Follis or a dedicated sonohyster cannula. You are seeing fluid coming there, and then later on it is collecting here. If that is seen, you can definitely say this tube is patent. Most of the times the tube is not placed like that, maybe anterior or posterior to the ovary. You will only see fluid collecting. Disadvantage of using saline is you know that one tube is patent, you don't know which of the two. Instead, if you are just seeing distension of the endometrial cavity and no fluid collection, it tells you yes, both the tubes are absent. If you want to know the site, definitely you can use color Doppler, put the color box around the ovary, and you would again the same image frame where you are seeing the uterus and the ovary, and you would see here as you inject saline, you would see some fluid coming here inside. We will see it in a while. And then you will see the color blush filling up the entire box. That tells you yes, that tells you the tube is patent. Whereas if you don't see that color blush, the tube is not patent. To see the entire tube, you can put air, which is what many people were doing, hyperechoic bubbles, and you can see the bubbles passing there, which tells you the tube is patent. But air is now banned because of the theoretical risk of air embolism. There are some people who are using betadine, there are some people who are using lignocaine also. Of course, it's a off-label use, it is up to your risk whether you want to use it or not. But SonoView is one dye which can be used very easily. It is an intravascular contrast. If you use contrast mode, you can see the entire tube along with the fimbria. Even on your 2D, see beautifully. Yes, but if at all the entire tube is not in a single 2D frame, then you can use a 3D. And the 3D will give you beautiful demonstration of the tube, entire tubal lumen, fimbria, and spill everything. Let me right away go to the deciding stimulation protocols. If I say deciding stimulation protocols, though we all decide stimulation protocols based on FSH, AMH, AFC, age, but that is all ovarian reserve alone. We have to understand there's something like ovarian response, and the ovarian response depends on the ovarian flow. If the ovarian flow is good, that is when more percentage of total gonadotropins loaded into the patient system is going to flow into the ovary every cardiac cycle, and therefore the FSH threshold is reached faster, and therefore total dose required for the patient is less. But when the ovarian flow is less, you will require more doses to be put into the patient system so that sufficient FSH is delivered to the ovary. So that means good flow in the ovary, patient is a good responder. Poor flow into the ovary, patient is a poor responder. Based on this, we have devised some baseline scoring systems. You can just evaluate the age, BMI, AFC, ovarian volume, stromal RI and stromal PSV. Do the scan on day 2, find out these readings, put them into the score system. And once you find what is the baseline score for a particular patient, there are fixed doses for IUIs, IVF fresh transfer cycles and IVF frozen transfer cycles. If it is only about 20% of the patients who may not respond on the first shot, and if they don't respond, that is the score chart. I'm not going to discuss this more in detail because we don't have time, but yes, we have charts for IUI and IVF patients both, and believe me, this is a zero OHSS method. Even when we didn't have agonist at all, even then it was a zero OHSS method. So this is something very reliable. You can use Doppler 2D ultrasound to evaluate the follicular size, but it is the Doppler evaluation which is very, very important whenever, so that is the Doppler evaluation which decides the follicular functional maturity, and therefore it is a very useful way to set the time of trigger. If you have multiple follicles, you can do what is called a sono AVC. Depending on the size of the follicles, you will decide what trigger to give, HCG or agonist or a dual trigger. Even for the endometrial assessment, of course, it's not only the thickness, you are also going to evaluate the morphology of the endometrium, which tells you indirectly about the follicular quality, and of course, the endometrial vascularity also. So I think I'm going to stop there, 30 minutes, and that's it. Of course, when you are evaluating the endometrium, uterine artery is also, evaluation is also important. It is Doppler PSV findings of the perifollicular flow, which will tell you you should do single IUI or you should do an earlier IUI for that patient or not. Whenever the PSV is more than 20, we prefer to do 2 IUIs, 12 to 14 and 36 to 38 hours. And of course, the procedures and the complications. Thank you very much for that very patient hearing.